you, Doug, and it's a pleasure to be back here in Austin. This is the first time I've been in this building over here. This is such a great space and such a great location also, and it's good to see Doug and Chris and Jeff. You know, you do learn new things over here, and I've known Jeff for a long time, but I never knew you were Jeffrey. Did your mother spell your name wrong, or did you?
99% of the time. It wasn't going to happen up there.
And it's good there's another Hawkeye over here. You know, Iowa's going to be playing for the NIT championship, and you know, when you win the NIT championship, the players are all going number one. But they should go number 70, because the other 68, 69 teams are all in the NCAA. My poor beloved Hoosiers, unfortunately, are not in the Final Four, but such is life. So I give a lot of talks to a variety of different groups, mainly medical groups, and I actually called Doug volunteering myself because of everything that's happened with Lance, with the organization, and I think we all felt a sense of loss and sadness with what's going on, and I just wanted to convey that I think what I do, I have the greatest job in the world. I take care of patients that have a curable disease. I can look them in the eyes and tell them that, yes, you have a new diagnosis of cancer, but everything's going to be okay, your life's going to be fine, we're going to cure your disease. You have the second best job. This is such a wonderful organization, and it's meant so much to not hundreds, thousands, but millions of patients around the world with cancer. And when you look at Charity Navigator and you see you're a 4-star organization, you're a 5-star organization if there were a 5th star, because the impact that this organization has is not just little checklist metrics, but it's meant so much to the cancer community. So I did want to just come here and just let you know how appreciative my patients are, and I am, of all the work that you do, and you should be justifiably proud of what you've been able to accomplish and will continue to accomplish. So just a little disclosure here. I do want to spend a minute or so, we're forced to do this here. We're talking a little bit about Lance, and you know, it's, I think Lance has probably lost his glamour in the cycling world, but he hasn't lost his niche as far as the humanitarian aspect. I don't think I have a single cancer patient who looks at Lance any differently now than they looked at him when he was in his glory. What he's done in setting up this foundation and the heart that he has in taking care of cancer patients around the United States and worldwide is really unparalleled. I take care of a lot of relatively wealthy and famous people with Tessa's cancer. No one has done what Lance has done in organizing this organization. And I've told Lance from the inception when this foundation started that his legacy is not going to be as an athlete. His legacy is what you have done and what he has helped to create with your help with the LiveStrong Foundation. And moving across the globe, about a year and a half ago, I had the privilege of taking care of another very famous athlete who is involved with a sport I know nothing about, and that's cricket. He's from India, and he's the #1 ranked cricket player in the world, Yuvraj Singh. And because he knew about the foundation, he is setting up, trying to replicate the same thing you have over here in India, still a developing country, a population of a little over 1 billion now, with healthcare disparities that are far more severe than what we have here in the United States. He never would have thought of setting up such a foundation were it not for this organization over here. So again, I think Lance's legacy is clearly not going to be, it truly is not about the bike, but it's going to be what he's done with the foundation. And if I were to try to come up with something poetic, probably the best thing I can come up with is something that Shakespeare wrote about Julius Caesar in his play Julius Caesar. And you probably remember some of these lines from high school where Mark Antony is giving his eulogy, and he says, "Friends, Romans, and countrymen, lend me your ears. I come not to praise Caesar, but to bury him. The evil that men do lies after them for years. The good is often interred in their bones." The good that he has done is going to far surpass any of the controversies as far as what's gone on at the present time. And I know that this is such a sad situation for everyone who loves the foundation and admires the work that he has done and this foundation has done. Well, I'm going to run through a little over a century of history in just a couple of minutes about cancer research to make a couple of points over here. This is William Halsted. William Halsted, at the late part of the 1800s, was a preeminent cancer surgeon in the United States, if not the world. And his philosophy of management of breast cancer, with the idea that you just do a more radical operation, you will cure the disease, remained prevalent for close to 100 years. It was called the Halstedian philosophy of management of breast cancer. We now know that that is erroneous and naive. Breast cancer, like so many cancers, is a systemic disease, and what affects our ability to cure the disease is the biology of disease, not a surgeon doing a bigger and bigger and bigger and more radical type of surgery. Professor Halsted had his issues also. He was addicted to cocaine, and again, when he was there at Hopkins, Hopkins really wasn't Hopkins. It wasn't the great institution that it was certainly at the present time. But certainly he was a founder of the idea of surgical oncology. This is a very famous picture in medical imaging. This is from Röntgen, who first discovered X-rays. You actually can use a machine and see what's going on inside the body. This obviously pales in comparison to MRIs, PET scans, and CT scans that we do today. This is his wife with a nice little diamond ring over there taking an X-ray. And of course, what wasn't realized was what happens with unprotected radiation exposure, leading to malignancy. Again, a lot of heroes from the past turned out to have their own foibles as to what was done with their field subsequently. This is one of my favorite pictures. This is Pierre and Marie Curie. The Curies were brilliant. They lived an impoverished life, never made any financial gain from their great discoveries. The two of them shared 2 Nobel Prizes. Over here is their daughter Irene, who later became a scientist in her own right, and she separately won a Nobel Prize. So if you want to strive to win a Nobel Prize, have parents who've won a Nobel Prize. So blame your parents if you fail in that endeavor over there. Now, Marie Curie, we probably wouldn't have a field of radiation oncology, radiation therapy, without the studies that she's done. There are bad things about this also, and not just late complications of radiation therapy. In the 1920s and 1930s, watchmakers used to have these little radium dials so that they would glow in the dark. And so the people working in factories would have a little brush where they would paint the radium dials with the numbers on the watch, and when the brush would become dry, they would lick it with their tongue and develop head and neck cancer. And in fact, that was the first discovery of radiation-induced malignancy. So here's something that's done something wonderful and something that's done harmful at the same time. This is Henry Kaplan, who's one of the fathers of modern radiation therapy. And his studies in Hodgkin's disease really was one of the first to lead to curing a metastatic malignancy, as opposed to a surgeon alone being able to cure localized malignancy. Dr. Kaplan was one of the most brilliant people of his time, but once again, a lot of time has passed and some of his philosophies have been proven to be incorrect also. He had the idea with Hodgkin's disease that you needed to localize where the disease was to better aim your radiotherapy beams. And so he proposed, and this was true for a quarter of a century, doing a staging laparotomy where we would open up the abdomen, remove the spleen, biopsy the liver, take out several lymph nodes, do a bone marrow biopsy to better define the stage of the disease. Certainly in 2013, that seems very naive, but nevertheless, that was standard of care for a quarter of a century. This is a famous war picture right after World War I, where the Allied soldiers in Flanders were exposed to nitrogen gas, nitrogen mustard gas. And with the mustard gas, many hundreds of soldiers died. And at autopsy, they died primarily of bone marrow failure with infection and bleeding. And so decades later, it was thought that if this noxious gas can dissolve bone marrow and lymph nodes, maybe it can be used as treatment for lymph node cancer, mainly lymphoma or leukemia. And in fact, in the 1940s, the very first chemotherapy drug ever devised was nitrogen mustard. And for many decades, it became a standard of curative therapy called MOP, nitrogen mustard for the M, oncomin is the O, P is prednisone, and P is procarbazine. We don't use this regimen anymore, but this was the first successful drug regimen based upon this terrible event that happened during World War I. Now you're probably wondering, what in the world does Babe Ruth have to do with the history of cancer research? This fine body over here is not the result of performance-enhancing drugs. It's the result of beer, ice cream, and hot dogs. Now, Babe Ruth was the most famous athlete of his time. In 1927, when he hit 60 home runs without the use of steroids, the following year he got an unprecedented salary of $100,000. And he was interviewed by the press, and they asked him, how in the world can he justify getting that much money, making more money than the President of the United States? And he quickly replied, I had a better year than he did. That was Warren G. Harding at that time, who was President of the United States. So why are we using him as an example? He was arguably the first person in the world to get cancer chemotherapy. He chewed tobacco, he had head and neck cancer, and he received nitrogen mustard, that same drug that I mentioned. Now, this was in an era where we didn't know what dosage to give, what diseases to treat, how long to treat someone, and so these lymph nodes that he had from his head and neck cancer melted away magically, but 4 weeks later they were right back again, and he eventually died from his tobacco-related head and neck cancer. Well, let me move to a little more modern times. I'm sorry that this doesn't show up, but this is platinum, or cisplatin. And this really is a drug that revolutionized the cure rate in testicular cancer. Before platinum was around as a drug, if a patient had metastatic testicular cancer, as Lance did so many years ago, that patient had a 90% probability of being dead within 1 year. Within 1 year. And most of these patients were in their early 20s at the time of diagnosis. Now, platinum was the first metal ever to be looked at as a cancer agent. And when I was a fellow at MD Anderson, this was one of many experimental drugs that we were looking at across a wide panoply of different diseases. And it was initially felt that the drug was having some interesting activity, but such severe toxicity that it came very close to being discarded as an overly toxic, minimally effective drug. And to give you a little history of platinum and how it came about that a heavy metal was looked at as a cancer agent, in the late 1960s and early 1970s, a variety of physical agents like hyperthermia, for example, were looked at as adjuncts to radiation therapy and cancer chemotherapy, with the idea that it would increase penetration through the cell membrane into the cancer cell itself. And so one of the whipping boys in biology is to look at E. coli, which is a way of looking at DNA. And you would set up a water bath solution, and you would dump E. coli into the water bath, and you would run this electric current through the water bath solution to see its effect on DNA, to see its effect on E. coli. So he wanted to see what the effect of the electric current would be. And all the E. coli were not only destroyed, but they became literally single filamentous DNA strands. And he was clever enough to realize this could not possibly be from an electric current per se. And that little eureka light bulb went off and said, maybe it's the electrodes that's moving the current through rather than the electricity itself. And you guessed it, they were platinum electrodes. He then synthesized a salt called cis-diamine dichloropplatinum, looked at it in a variety of animal tumors. It had activity in animal tumors. And so in 1973, the first human to get cisplatin was looked at. Now, when we give chemotherapy drugs, we expect, even way back in 1973, hair loss, nausea and vomiting, lowering of the blood counts and potential for infection. But this was different. This caused horrendous nausea and vomiting, unprecedented compared to any drug that had been used previously. And for those patients who responded to the drug and would get a second course 3 weeks later and a third course 3 weeks later, a very high incidence of developing acute kidney failure and severe toxicity, what we call peripheral neuropathy, with pain and numbness and tingling in the hands and the feet, hearing problems with deafness and ringing in the ears. So platinum was used in several dozen patients, and at a phase 1 meeting that the National Cancer Institute convened, the thought was that the drug had some activity but was way too toxic and was about to be discarded. What saved platinum from extinction was testicular cancer, just as platinum saved so many lives from being extinguished with metastatic testicular cancer. Because admixed with the several dozen patients who were getting cancer treatment with this drug as an experimental agent were a mixing of a few patients with metastatic testicular cancer who had failed previous quote-unquote standard chemotherapy regimens. And the fact that they would get this as third-line therapy after failing first-line therapy and second-line therapy, and having these masses melt away, made us as a society realize this drug is too good to throw away, and we need to figure out how to overcome the toxicities. And we have. We have far more effective antiemetics to prevent chemotherapy-induced nausea and vomiting. And to give you an idea of how it used to be in the 1970s for a patient getting platinum, platinum was given for 5 days in a row every 3 weeks for 4 courses. On day 1 of the first course, the average patient would vomit 12 times. That's day 1 of a 5-day course, with another 5-day course 3 weeks later, 6 weeks later, and 9 weeks later. Today, the average number of vomits for day 1 is 0. We have not eliminated chemotherapy-induced nausea and vomiting, but a far cry from what it was before. As far as the kidney toxicity, we realize that this is not unique to platinum. We see it with other heavy metals like mercury causing the same kidney toxicity. And there, the expedient of just making sure a patient is well hydrated and to force a diuresis so that the drug does not accumulate in the kidneys totally prevents kidney damage. All we need to do is hydrate the patients with salt water or IV saline, give the platinum, and give another liter of IV saline so that the force the drug out and it doesn't accumulate in the kidney. So again, if a drug works, we can figure out as a scientific community how to mitigate and how to ameliorate the toxicity of this drug. Later, after the first patient to get platinum in the world, and there is no other drug like this. This is first-line therapy for 11 different malignancies. Obviously, testis cancer is the miracle disease for this miracle drug, but nevertheless, we prolong survival, have occasional cures in these type of diseases over here based upon platinum, a drug that almost got discarded as a uniquely effective drug in testis cancer with a wide array of activity in many other diseases as well. So I want to spend a few minutes talking about what we've done at Indiana University with testicular cancer. And as probably most of you know, most cancer affects middle-aged or elderly patients rather than young patients. This is a young man's disease. Most of our patients are in their 20s and 30s when they are diagnosed. They're perfectly healthy. It is not a smoking-related disease. No one knows why people get testicular cancer, but it affects a young, obviously male patient population. It accounts for only 1% of male malignancy. We see 8,000 cases a year in the United States. The most common male malignancy is prostate cancer, a disease where the average age is in the 70s, where we see about 220,000 cases of prostate cancer each year. This is an important disease because we play well together with other modalities. We combine surgery and chemotherapy to cure patients that would not be cured with chemotherapy alone. It also has become a nice model for making important discoveries and important scientific conclusions by doing randomized studies, which I'm going to get to in a few slides over here. It's been a nice harbinger for new drug discovery. There are 3 cancer drugs that were first approved by the FDA purely based upon their activity in testis cancer. Platinum, which of course is the most important of any chemotherapy drug that we use today, BP16, its other name is etoposide, and ifosfamide. And obviously, when we treat metastatic cancer, most of the time we confront a patient and their family and we explained that the goal of therapy is to palliate symptoms, to prolong survival, but not to cure your disease. In testis cancer, the one and only goal, and we achieve this in the great majority of cases, is to cure the disease. So this is what used to be used before platinum existed, actinomycin D. And yes, actinomycin D did have occasional cures. About 5 to 10% of patients were cured with this drug. Two other drugs became available in the 1970s that were neither better nor worse than actinomycin D. But when the two drugs were combined, they were not merely additive, but they were super additive or synergistic, not having a 10 or 15% cure rate, but a 25% cure rate. And then platinum comes around in 1973. Now, when we look at an experimental drug in patients who have been treated with previous regimens, we get very excited if, as a single agent, we see a little glimmer of activity. Well, with platinum, not only do we see partial remissions, but we saw complete disappearance of pulmonary metastases with single-agent cisplatin. Now, none of these 11 patients were cured. They all died of their disease because this was third-line therapy, single-agent therapy. But it allowed us to have a new kid in the block, so to speak, that could become a component of a curative combination chemotherapy regimen. And this was our original 1974 PBB, platinum, vinblastine, bleomycin, two of the older drugs that I mentioned on the previous slide. Now, in 1974, if there was a model for a curable neoplasm, it was a wonderful work from St. Jude's Hospital in Memphis with childhood acute lymphoblastic leukemia. And in that model, it was felt that in order to cure a neoplasm, we had to give long duration maintenance therapy. Ergo, in this particular study, we gave platinum and bleomycin for 12 weeks. These two drugs have cumulative toxicity. Vinblastine, which does not have cumulative toxicity, then continued for a total of 2 years of chemotherapy. This study started at a time where the average cure rate was 5% with actinomycin D in this country. And even in my youthful exuberance, I never would have dreamed that the introduction of an experimental drug would so change the cure rate. And in our very first phase 2 study with 47 patients, most of whom were cured with chemotherapy alone, a few with the additional surgical resection of lesions, we wound up literally having a 1 logarithmic increase in the cure rate from 5% to over 50, in this case 64%. And just to show you one or two examples, this is a patient that came to us critically ill. This obviously is a chest x-ray. Most of his lungs is filled with tumor. This is a lateral view of the lung. And the black is normal lung, all the white is cancer here. And this patient was critically ill. And to be honest with you, even in 2013, if this were any disease other than testicular cancer, we would have referred this patient to hospice, as critically ill as he was. But this is testis cancer, and we cured his disease. This is another one of our patients, again, with massive pulmonary metastases, again, long since cured of his disease from 1980. And finally, this is a CT scan showing extensive disease in the liver, as well as, not shown on this slide, extensive disease in the lungs, again, long since cured with chemotherapy. Well, if a treatment works at Indiana University or in Texas or in New York or anywhere else, we should have technology transfer and should work everywhere in the United States and worldwide. And so when we first presented our paper with PBB, platinum, vinblastine, bleomycin, at a scientific meeting and published it, and it became a standard therapy, we had this remarkable upward swing in the cure rate in patients with testicular cancer. And I wish many decades later we could show similar type of slides in breast cancer, lung cancer, colorectal cancer. This is sort of the unique, at least for me, walk on the moon, so to speak, that you have once in your lifetime, where you're involved in a drug that really makes such a monumental change rather than a minimal change in improving the cure rate in an individual cancer. Well, as the years moved along, we refined the cure, so to speak, and another experimental drug became available, VP16. Its other name is etoposide. This is a mouse model. In a mouse model where the mice live for only a couple of months, it's very easy to see if a drug works. It's very easy to see if combining two drugs is synergistic rather than just additive. So you can inject tumor cells into the undersurface of a mouse's abdomen. It takes a couple of days, you see tumor nodules develop, and if you give single agent cisplatin, as opposed to doing no chemotherapy at all, the mice live a few days longer. If you give single agent BP16, the mice live a few weeks longer. The mice all die. But if you combine this drug with this drug, you have this remarkable synergism, and 25% of the mice are cured. Now, the literature is replete with things that work in the mouse model and do not work in the human model, because this is a transplanted tumor. We gave the mouse cancer, so to speak, rather than the spontaneous development of cancer, which is a far more complex organism, obviously. But nevertheless, we use this as a background to look at this type of regimen for patients who were not cured with PVB, their initial chemotherapy. And much like the mouse model, about a fourth of these patients were cured. And this is the first time in an adult that we had ever cured someone with second-line chemotherapy. So with that as a background, we then did a clinical trial substituting etoposide or BP16 for vinblastine in this phase 3 trial. And in this study, we actually had less toxicity with BP16 and a higher cure rate with BP16. Now, we did several other phase 3 studies during this time. We demonstrated that we did not need to give 2 years of therapy. We randomized patients to 12 weeks versus 2 years. There was no difference. And then once this became standard therapy, we now call this BE for etoposide P, BEP. We randomized patients to get 3 courses of therapy versus 4, 9 weeks versus 12 weeks, and demonstrated that we can maintain the same therapeutic cure rate with just 9 weeks of therapy. So over about a decade of time, as we refined the cure, we had higher and higher cure rates and less morbidity, cost, and inconvenience to the patient, going from 2 years of therapy to 4 courses or 12 weeks to 3 courses or 9 weeks of chemotherapy. Well, what do we do if we fail to cure someone with what now is standard first-line therapy, BEP? So we have been looking at high-dose chemotherapy since 1986, and my former colleague Craig Nichols gets the credit for discovering this type of avenue of research. So the idea of doing bone marrow transplant, we now call it peripheral blood stem cell transplant, is that you can give drugs whose main toxicity is low blood counts in 5 times the dosage and not kill the patient with sepsis or bleeding from low white blood count or low platelet count by giving them back their own healthy blood cells. So this is not a transplant from a brother or sister. This is an auto transplant. Now, this technology is safe and it can work, but it's only logical if you have good drugs. Cisplatin, the miracle drug in testis cancer, its toxicity is neurological damage, kidney damage, hearing difficulties. If we gave that drug in 5 times the dosage, patients would be on dialysis permanently, they would be deaf, and they would be crippled. In 1986, a new platinum became available, carboplatin. Its toxicity was myelosuppression. So it became logical to look at high-dose chemotherapy once we had the right drugs. The second best drug after platinum is etoposide or BP16. Its only major toxicity is lowering of the blood counts. So this has worked very, very well in testis cancer, as I'll demonstrate. Many of you may realize that that same type of philosophy was tried in breast cancer and was a dismal failure. And it's a predictable dismal failure because the drugs that are used in breast cancer that can be used for high-dose chemotherapy are not very good drugs. The best drugs in breast cancer cannot be escalated to 5 times the dosage, so they're not part of a bone marrow transplant type of regimen. Also, women who have breast cancer commonly have bone metastases. When you have bone metastases, you have bone marrow, which is your factory that makes your blood cells. So one would give someone high-dose chemotherapy and give them back their healthy bone marrow, but it was a diseased bone marrow, so we were giving them back their own tumor cells after we were given the high-dose chemotherapy. So it was no surprise that this type of philosophy that generated so much enthusiasm in the early 1990s turned out in phase 3 studies to be a totally flawed hypothesis. So this is data that we published 5 years ago in in the New England Journal of Medicine. So this is looking at 184 consecutive patients who failed to be cured with BEP or similar therapy. And this is just a nice, and this stands for peripheral blood as opposed to bone marrow, peripheral blood stem cell transplant. And this truly is miraculous, probably the most miraculous thing that we do about testicular cancer. Even when we fail to cure people with BEP, we cure over 60% of the patients. Even when this is used as third-line therapy after failing 2 different forms of therapy, we cure almost half of the patients. The term platinum refractory means that the cancer has progressed within 4 weeks of standard dose platinum. We give high dose platinum and we cure 45% of the patients. Now, ending up about testis cancer, this is what survival curves used to look like before platinum was around. If you had stage 1 disease confined to the testis, stage 2 disease confined to the abdominal lymph nodes, a surgeon would have a 90% or a 50% cure rate. If it spread to the lungs, almost all patients were dead within 1 year. The 5-year survival was about 5%. And as Doug alluded to, we now cure 95% of the patients, including those that present with pulmonary metastases and beyond, such as Lance obviously had. 80% of patients who were diagnosed with far advanced metastatic testicular cancer, 80% of those patients will be cured of their disease. Well, as I mentioned at the beginning, I have the greatest job in the world because I deal with mainly testicular cancer. Before that, let me just go over something that's very important for the foundation here, and that's survivorship and late consequences of therapy. So it's a luxury to be able to look at things that can happen 5, 10, 15 years later because most metastatic disease patients aren't alive 5, 10, 15 years later. So we are part of an international consortium that we have an NIH grant from, looking at obtaining DNA and looking at various aspects of late consequences of therapy. The most feared is getting a malignancy due to the therapy itself, be it radiation therapy or chemotherapy. The E drug and BEP, etoposide, 1 out of 500 patients, it doesn't seem like much, gets leukemia because of the drug. If you have to get high-dose etoposide with bone marrow or peripheral blood stem cell transplant, about 3% will get leukemia, and that's one of the most tragic things that happens. It's not just leukemia, but a variety of other malignancies we see in an increased incidence. It's a low increased incidence, and the prevalence are the things that we're going to be looking at in this NCI study that we're doing internationally, but it certainly is above and beyond what a normal patient population that is young would be expected to endure. The drug platinum can be measured in the urine 20 years later by atomic spectroscopy. It's probably not a good idea to have a heavy metal in your body 20 years later, and this may or may not be part of the reason why we see these second malignancies. Cardiovascular disease, congestive heart failure, myocardial infarctions are seen as a result of a late consequence of therapy. Fertility issues are of primary importance, and I know this organization has done so much with Fertile Hope. So when we cure someone with chemotherapy, 40% of the time they will be permanently unable to father a child. This is why sperm banking or more sophisticated techniques like testicular sperm extraction can be done, which, by the way, as you probably know, is often not covered by insurance and not inexpensive. Hypogonadism means that normally when you have one testis remaining, the testis will work overtime and the patient will make a normal amount of testosterone, but about 20% of the time it doesn't. Now, when a male complains of erectile dysfunction, difficulty having and maintaining an erection, weakness and tiredness, most men are aware this may be a symptom of a low testosterone. Less well known are irritability, depression, insomnia, and when women go through menopause, they have hot flashes. When a man has low testosterone, they have night sweats and increased sweating. So these are things as physicians that we learn to ask about with survivorship issues because this is treatable. There's nothing you can do about this. You're not going to not give a curative therapy, but these are things that we can do something about. Now, furthermore, chronic low testosterone leads to something called the metabolic syndrome. What is a metabolic syndrome? It's associated with truncal obesity, insulin resistance, elevated lipids like triglyceride and cholesterol, early heart disease, hypertension. So part of the reason for the cardiovascular disease can be manageable by just recognizing hypogonadism. So what are potential preventative strategies and what can we do about it? Well, in a patient with seminoma, which is the one and only type of testis cancer that we use radiation therapy, we've learned from phase 3 clinical trials that we can use less and less radiotherapy with a smaller and smaller field. And for those patients that have disease confined to the testis, radiotherapy used to be standard therapy, kind of like the Halstedian radical mastectomy. We don't do this. We don't think anyone should get radiotherapy for stage 1 disease because they have an 85% cure rate with orchiectomy alone. If they recur, they're going to have a 100% cure rate with subsequent therapy. So these are some preventative strategies that we can do. I talked about metabolic syndrome. This is very important not just for cancer patients, but for everyone in the room. We should all lead a healthy lifestyle, but especially if you've been a cancer patient. We've talked about sperm banking and fertility issues as well. And we do lifetime follow-up on patients, not just because of the late complications. 1% of people who are cured of testis cancer will get a cancer in the other testis. 2% of patients beyond 5 years will have what we call a late relapse. That late relapse is easily curable as long as we pick it up at an early level rather than an advanced disease, and maintaining a healthy lifestyle. Here in Atlanta, this is sort of the top 5 as far as cancer statistics, so to speak, with causes of death. And I think if you do fast mathematics, you realize that this disease here, lung cancer, exceeds number 2, number 3, number 4, and number 5 causes of death combined. 85%, not 100%, 85% of patients with lung cancer are smokers. 15% are never smokers. It's easy to know why most people get lung cancer. We don't know why the 15% who are never smokers get this terrible disease also. And for the last 15 years, lung cancer, not breast cancer, has been the number 1 cancer cause of death in women, as well as the overwhelming number 1 cause of cancer death in men. So we are learning a lot more from the days of looking at nitrogen mustard as a chemotherapy agent. We now have science to look at what makes a cancer cell a cancer cell, what distinguishes it from a normal cell. And this is above and beyond the scope of a non-PhD audience, but these are 2 articles in a journal called Cell, published in 2001 and a decade later, just going into what are the molecular differences that differentiates a cancer cell from a normal cell, because it is a normal cell that's gone awry. And we talk about cancer being a genetic disease. Why do we say it's a genetic disease? Not because you inherit it from your parents, but because we all have over 20,000 genes in our body. All it takes is 1 mutation in 1 gene, and that's what leads to what we call cancer. That's why we refer to it as a genetic disease. We are now beginning with the Human Genomes Project and so much more sophisticated science to be able to look at an individual patient's genome and figure out which mutation they have, and hopefully to be able to develop a drug that blocks that driver mutation so that we can truly personalize therapy. We quite honestly don't need to do this in testis cancer because platinum is so unbelievably effective. But the rest of the panoply of malignancies that we deal with, we have a long way to go with metastatic disease. And these are a couple of the drugs that we use in various different diseases. These are non-chemotherapy drugs. This is science finding a driver mutation that drives the pathogenesis of a cancer to spread and develop metastatic disease that can be therapeutically exploited. Sometimes we find a driver mutation and there's no drug that blocks that particular mutation that we can use. But these are some nice success stories. This is Herceptin, that I'm sure you've probably heard of in breast cancer. Trastuzumab is its generic name. And even diseases as dismal as lung cancer, we have 2 specific mutations, EGFR, epidermal growth factor receptor, and anaplastic lymphoma kinase, where we have 2 exciting oral, well-tolerated agents that can put disease in remission for a year or 2. It's not testis cancer, but it's a year or two longer than patients would survive with testicular cancer before this science was discovered. And this is one of our patients treated with crizotinib, one of these oral agents. This is as good as we do with testis cancer with this dramatic response, but it's not testis cancer, and about 18 months later the cancer came back and eventually the patient died, but certainly producing a very dramatic quality of life and quantity of prolongation of survival with this new drug. And this is an interesting machine here. It's called the ion proton sequencer. We just got this at Indiana University this year, and titling it "The Future is Here." We have the capabilities of taking a drop of blood and a little bit of tissue from a biopsy and looking at the entire genomic analysis of that tumor so that we can personalize therapy. So we bring in a sample at 8 o'clock in the morning, and believe it or not, by 5 o'clock we have a result. It gives us an entire genomic analysis. It allows us to look at all mutations that literally thousands and thousands of genes can be simultaneously analyzed. And then we can look through data sheets to see if you have a mutation, is there a standard or experimental drug somewhere in the United States that a patient would be eligible for a clinical trial. And the cost of this is really getting to be quite reasonable. It's $3,000 per patient. It's not cheap, but that's the same testing that we do for one particular gene for hereditary breast cancer. Breast cancer 1, BRCA1 or BRCA2, which costs basically the same type of amount of money. So again, the future is not in the future anymore. It's here that we really can individualize therapy by looking at these genomic mutational analysis and individualize therapy rather than giving everyone the same type of treatment. So I want to end up in the next couple of minutes. This was a very famous book a couple years ago, The Emperor of All Maladies, and I recommend it highly. It was written by a fellow at Dana-Farber Cancer Institute in Boston, and it's a biography of cancer, literally and figuratively. And I think their fellows probably have a lot more free time than our fellows have. This really was a monumental undertaking. This is the quote from the book. You can read it yourself, but I'll read it anyway. In the end, cancer truly emerges, as a 19th century surgeon once wrote, "It is the emperor of all maladies, the king of terrors." And getting back to Lance Armstrong again, this is what he looked like. And it is the emperor of all maladies, the king of all terrors. But it doesn't have to be anymore. Testis cancer shows us that we can do science, we can look at a new experimental drug, we can do clinical trials, and really change the face of a disease. And I want to talk about a different L patient. This is not Lance, but this is a woman that I treated because my other field of research is lung cancer. So this particular person, back in 1977 at age 10, she developed childhood Hodgkin's disease. Now, this gets back to Henry Kaplan's era where staging laparotomies were done to stage the disease and define how much chemotherapy and radiotherapy was given. So her disease was above the diaphragm, so she had radiotherapy to the chest and neck and chemotherapy. This was 1977. We wouldn't do this in 2013, certainly. Radiation can cause breast cancer, it can cause lung cancer in the radiated field, leukemia and lymphoma. So she was cured of her Hodgkin's disease, but 24 years later, she was diagnosed with advanced lung cancer due to her prior radiotherapy. She's a never smoker. In the interim, she went to our university, Indiana University, married, and has 2 children, ages 1 and age 3, when she developed advanced lung cancer as a never smoker. So the chest x-ray revealed this large mass. At a different hospital, a surgeon attempted to resect it because surgery really is the only curative option, but this was so far advanced it was an open and closed surgery. And so she came to see me for the first time in June of 2001 with a disease that has an expected survival of 9 to 12 months, and having survived childhood Hodgkin's disease with a 1-year-old and a 3-year-old. So we gave her chemotherapy, not with the illusion of curing her disease, but to try to shrink her tumor to the point where we can try surgery again, because again, that's the only chance of eradicating her disease. The chemotherapy did little or nothing. So she met with one of our very talented thoracic surgeons, Dr. Ken Kessler, And Dr. Kessler basically told her that trying to do surgery is what he referred to as a high risk, significant morbidity and a chance of dying on the operating table, and low yield, low chance of being able to get the tumor out completely. And he told her quite honestly that she might die on the operating table. He also told her that because of her staging laparotomy that she had when she had her Hodgkin's disease, something we don't do anymore, with the removal of the spleen, it had damaged the diaphragm on the good lung. And so the good lung wasn't going to function normally if they took out the bad lung, and she probably would have to be on a ventilator for about a month. And she looked Dr. Kessler in the eyes and says, Dr. Kessler, I have 2 small children. If I die on the operating table or if I die in 6 weeks, it doesn't matter. If you think there's any chance of helping me, I wanted to go ahead with the surgery. So the surgery was done, and there was a great deal of difficulty doing the surgery. She did indeed remain on a ventilator for 6 weeks, but the tumor was completely removed. This is September of 2001. A little less than 2 years later, and it's a miracle she's alive 2 years later, in July of 2003, she develops headaches. That prompts getting a head MRI, and she has a brain metastasis from her lung cancer. That was her only evidence of disease, and so this was resected and followed by radiation therapy to the brain. In June of 2005, 4 years later, she came to my office with some flowers for a gift because she said this was her kindergarten anniversary. I get choked up even thinking about it here. So her 1-year-old had just graduated kindergarten, something she never thought she would see. Here she is 8 years later, in March of 2013, remains cancer-free, 12 years after a diagnosis of incurable lung cancer, 10 years after brain metastases. This is why you do what you do. This is why I do what I do. This, unfortunately, is not a complete story. This woman also carries the BRCA1 gene, which leads to breast cancer and ovarian cancer. Last year, her mother died of ovarian cancer. She, thus far, is disease-free as far as breast and ovarian is concerned. And for those of you who are not familiar with BRCA1, you have a 50% chance of developing breast cancer by age 50, and 85% chance of developing breast cancer eventually, and a very high chance of developing ovarian cancer. And what this woman has gone through and her courage is really amazing. So this is a quotation that I use. Death and pain are both part of the human condition and part of all religions. The former may be delayed or cheated, but it is inevitable for all of us in this room. All who have ever lived must eventually die, but not all who die have ever lived. However, the occurrence of pain is also inevitable, but unlike death, does not need to triumph. So we look at survivorship issues in testis cancer patients who are cured of their disease. Again, it's a luxury to be looking at this, but we also look at lung cancer patients who we know are going to die of their disease. We make a covenant with them. They're not going to suffer from pain. We may not be able to control the inevitability of death in a lot of these patients, but we can improve their quality of life. And survivorship issues, and literally every day is a gift, and every day is precious for all of us, and especially people who have limited survival with diseases like lung cancer. And I was recently with my wife Claudette in Portugal, and I'm Jewish and I don't know anything about saints, but this is Saint Barbara, one of the minor saints. And so I was reading this little thing that was translated from Spanish to English as to who Saint Barbara is. Does anyone know who Saint Barbara is? So let me tell you the story of Saint Barbara. It's very interesting. So Saint Barbara's, her father was a pagan, and so she embraced Christianity. And this is the worst father ever. So because she embraced Christianity, he had her imprisoned and had her sentenced to death because she wasn't following the pagan gods. So friends of her allowed her to escape from the prison. She was free, but then she was captured. And her father, in order to punish her, had her stripped naked, paraded in front of the city before she would be executed. And the angel of God appears, and the angel of God clothes her, puts her clothes back on, but she's still executed. And so I say to my wife, Claudette, if the angel of God is so powerful, why didn't the angel of God save her life? And Claudette had a very good answer. It's death with dignity. And that's what this is. And that's what we try to do also. So this is a statement from the former director of the NCI. Our goal is to eliminate pain and suffering from cancer by the year of 2015. This is science fiction. This is not going to happen. We'll never eliminate cancer, quite honest. It's a disease of aging. As we get older, our genes become mutated, just as we get heart disease, strokes, diabetes, and other things. So cancer, of course, is hundreds of different diseases. We're never going to eliminate cancer. We're going to improve quality of life. We're going to be curing more and more cancers, but we're not going to be eliminating cancer. And this reminds me of another science fiction, The War of the Worlds, which was good old Tom Cruise in the Church of Scientology there. But The War of the Worlds, this was a novel by H.G. Wells that was written just about 100 years ago. And this is one of my favorite quotes. This is from H.G. Wells. The disease of cancer will be banished from life by calm, unhurrying, persistent men and women. This was 100 years ago. Working with every shiver of feeling controlled and suppressed in hospitals and laboratories. And the motive that will conquer cancer will not be pity nor horror. It will be curiosity to know how and why. And so with that, I'll end, and thank you very much for your attention.